Assalamu alaikum. Our lecture today is about limb length discrepancy. Limb length discrepancy in children is a frequent parental concern or physical finding noted by the orthopedist. It is commonly identified incidentally during screening examinations, such as those performed on armed forces recruits. The management varies from no treatment at all to extensive multi-stage reconstruction to limb ablation and prosthetic fitting, depending on the severity and the function of the limb. A difference of 1 to 2 centimeters in length or circumference was reported in the normal population. It's considered individual variation. Limb length discrepancy is defined as more than 2.5 centimeter difference between the two lower limbs. The types are static and progressive. Static, like malunion of a fracture of the lower limb, of course. Progressive, like physical growth arrest of one limb. Differential diagnosis includes congenital and developmental conditions and acquired conditions. Here is an algorithm for the differential diagnosis. The congenital, it may be anomaly or a disease. Anomaly may be transverse or longitudinal. Transverse, the example is for terminal transverse amelia and for intercalary phocomelia. Longitudinal, terminal, the example is paraxial hemimelia, the intercalary proximal hemimelia. The diseases may be dysplasia, like fibrous dysplasia, neurofibromatosis, or Olier's disease. The vascular disease, like Klippel-Trenaunay syndrome. Acquired may be idiopathic. Developmental, like DDH, Coxa-Vara-Clown's disease. Traumatic, physical injury, infections, septic avascular necrosis, tumors, and their treatment or their management may cause physical arrest. Neurological, like polio and CB, cerebral palsy. Another table showing the causes of the limb length discrepancy. The acquired condition limb length discrepancy is a potential complications after long bone fractures, like femoral shaft fractures. It may develop from malunion, growth stimulation, or subsequent disturbance of physical growth. The impact of the limb length discrepancy is not only a cosmetic concern with the limbing, but also a function concern. The short leg gait is awkward, is difficult for the patient, increased energy expenditure due to increased vertical rise and fall of the pelvis or compensatory ankle movements. Compensatory mechanisms include circumduction of the limb, of the long limb, or persistent flexion of the hip and knees of the long limb, or vaulting over the longer lower limb, or walking on the shorter lower limb. Lower limb length discrepancy may result in development of scoliosis, secondary scoliosis, or compensatory scoliosis, low back pain, sciatica, increased stress on the other joints of the lower limb from the hip, knee, and the ankle, and may be dysfunction of the lower limb and may end with stress fractures. The assessment should be incorporated into screening examination programs as all children must be examined because they can tolerate and mask even substantial limb length discrepancy. Significant malformations such as congenital clubfoot deformity, skin discoloration, or soft tissue enlargement should be investigated. Maybe a hint, maybe a clue for neurofibromatosis case, for example, or myelomeningocele. The assessment of limb length discrepancy starts like any case in medicine. First with history. How long the family has been aware of limb length discrepancy? At what age of the child? Any associated function limitation in either lower limb, like flexion deformities? History of fractures, infections, or other significant injury to the lower limb, maybe surgery to the lower limb, family history of skeletal dysplasia. The types of limb length discrepancy are structural, in response to a measurable difference in the lower limb segment, or functional, secondary to asymmetry in the positioning of one lower limb relative to the other, or mixed. The assessment includes careful measurement of the length of the lower limb and their segments, an evaluation of the range of motion and the resting position of the lumbar spine, hips, knees, and ankles. Here's the photo showing limb length discrepancy. The right limb is shorter than the left. Here is the block test to the right. We put wooden block below the short limb till the pelvis becomes leveled. On the left side, the pelvis is unleveled. The right pelvis is down more than the left. But when you put the wooden blocks below the shorter limb, the pelvis becomes leveled. Then we do the X-rays. We do standing X-rays. Then we can do what's called cytoscanogram, showing all the lower limb from the pelvis to the ankles. The treatment may be very simple, like shoe lift of the shorter side, epiphysiodesis of the long leg to allow the shorter to reach its length, shortening of the longer leg in patient too old for epiphysiodesis, about the epiphysis about to close, the physes are about to close around 16 to 18 or 19 years, lengthening of the short legs. Here is epiphysiodesis. We use some kinds of plates to prevent the growth of the physes of the longer limb. Here is lengthening of the limb around an intramedullary nail. Here is lengthening of the limb by Elizarov apparatus, which is a type of external fixator used in open fractures and also used in limb lengthening procedures. Another way of lengthening over intramedullary nail. Thank you.